The knee joint is the most injured joint in the body, and thus a thorough examination is very important. My examinations always begin with a patient in a standing position and looking for any obvious deformities, such as varus or valgus deformity. It's also useful to look for any tilting of the hip. It's also important to look at the knee from the side. Squats may be used to also assess for overall function of the leg, and we're looking for any asymmetry of the hip during the squats, or any internal rotation, which might be a sign of any ligament injuries such as ACLs. The next part of the examination is completed on the bedside, and here we like to examine the knee. First, we begin with observation of the knee, and we're comparing both sides, looking for quadriceps atrophy, looking for any swellings, obvious deformities, heat, or any scars, which might be suggestive of surgery. And it's always important to look on the underside of the knee. I then begin feeling different parts of the knee, such as the tibial tuberosity to begin with, and then looking for joint line tenderness, both medially and laterally, and it can help putting the knee in flexion during this part. Then I feel around the patella, feeling both the patella tendon, the quadriceps tendon, and the actual structure of the patella to see if there's any pain that can be elicited. The patella tends to dislocate laterally because of the structure of the knee, and we can try and rotate or move the patella from side to side to try and elicit any pain, which might be a sign that the patella is dislocated laterally. We can also test for effusions around the patella, and this can be a sign of ACL injuries, ligament injuries, or even meniscal injuries. We can use the patella tap to see if there's any small effusions, or try to squeeze fluid into the knee to see if there's any other effusions. We can then feel the knee posteriorly, looking for any Baker's cyst in the popliteal fossa, and feel for any other abnormal structures. It's also important to feel if there's any tenderness around the tibular-fibular joint, and always comparing again the knee from side to side. We then move on to the movement side of the assessment of the knee, starting with a straight leg raise, which can tell us about the quadriceps strength, then flexion and extension of the knee. Full flexion extension range should be 150 degrees in flexion and 15 degrees of extension. We then move on to passive movement of the knee, flexion and extension. And we can also use this to track the patella during flexion or extension to see if there's any pain elicited or any abnormal movement of the patella. We can then move to resisted movements of the knees, testing for resisted flexion and resisted extension, which gives us an idea of the function of the hamstrings and the quadriceps as well. It's also important to test resisted straight leg raise, which is also another assessment of the strength of the quadriceps muscle. We then move on to our special tests. Our first special test begins with the anterior draw, which tests for ACL, and you're looking for tibial movement anteriorly on top of the femur. Then the posterior draw, testing for the PCL, looking for posterior movement of the tibia in comparison. The Lockman's test is another test for the ACL, where we are looking to feel the end of the point of range of movement of the ACL, which usually has a softer end in deficiency. Then MCL collaterals are tested, and LCL collaterals are tested to see if we can elicit pain when we're putting a varus and valgus force. McMurray's test is used to try and trap the meniscus during movement of the knee. Here, I'm trying to test for the medial meniscus while feeling the medial joint line while flexing and internally rotating the knee. And here, I'm feeling for the lateral meniscal injury, feeling the lateral joint line tenderness as I flex it and then extend the knee as well. A positive sign is pain or popping and clicking of the knee during this movement. The next test here is a pivot shift test, which is another test for ACL injuries, where the tibia is internally rotated in full extension and then flexed, and we're looking for a clunk during flexion, which is specific for an ACL injury. Our final special test of the knee is the Apley grind test, which is done in a prone position, and we're trying to test for any meniscal injuries here. Here, we place our knee in the front and try and place some rotation forces through the knee to try and elicit pain, while loading the knee as well. This can be a sign of any meniscal injury. Again, while we're in this position, we take the opportunity to compare the knee posteriorly, looking again for any atrophy, swellings, or any deformities. Finally, we move on to the functional tests of the knee, which are very important. Again, we do our single leg squats here to see the strength of both knees, and we need to look at a side position and a front position as well. I like to compare the knee both in a single leg squat and a double leg squat because it's easy to compare symmetry as well of the knee during this time. Single leg hops are also useful to compare the strength of the knee and if they're able to return to sport. We then need to assess the gait. We get them to walk forwards, turn around, and then walk backwards. And it's important to assess both from the side and anteriorly. Then on tiptoes, back and forth, and then on their heels, back and forth. It is important to always comment on the gait and if they have a normal walk, if they're flat-footed, high arch palate, any deformities that might put them at risk of injury to the knee. A prone can be useful to assess the core stability of the patient. If a patient has poor core stability, they may be at risk of further knee injuries while playing sport. Finally, a step up and then a step down can be used as another functional test of a patient. This completes my examination of the knee, but I would also consider doing other investigations such as radiography to ascertain the extent of damage. You should always examine the joint above and below, and especially in the case of the knee, where the hip joint can refer pain down to the knee. Simple movements of the hip like this can determine where the source of the pain is.